Okay, so we left off actually at BSI. BSI means what? It means bloodstream infection, right? BSI, bloodstream infection. So what does CR-BSI mean? So it's catheter-related, right? Catheter-related bloodstream infection. So catheter-related bloodstream infection, you can think of that as CURB-C, which is how you say it. CURB-C is the acronym, which is catheter-related bloodstream infection. And treatment, what is the treatment? So there's three. There is vancomycin, ceftazidime, and catheter removal and dialysis. So you want to remove the catheter, obviously, right? It's almost like the very first thing you do. It is the very first thing you do. And then you want to use ceftazidime, which I've labeled here as a third generation. This is just a recap from last time. And then I recommend that you watch this video 2x speed. And this is a step 2 CK review of really high yield questions. New questions that have just been added to QBank as well. So what post-infectious cause results in obsessive compulsive behaviors? SC. So SC is a post-infectious cause this is not a great sentence, but that results in obsessive compulsive behaviors. So SC, what is that? It's Sydenham chorea. And what is the pathophysiology? So it's mimicry of gangliosides on the surface of basal ganglia. So the gangliosides of the base of ganglia are actually similar to group A strep, right? And so you can have a rheumatic fever rheumatic heart disease, wherein post-infectious mimicry causes you to have an type 2 autoimmune attack of your basal ganglia as a result of these gangliosides, which was similar to some antigen on the surface of this infectious agent. So what 4 signs? Bacteria. So you have chorea, which, by the way, means dance. And then, so it's jerky, irregular, involuntary contractions of the limbs and face that cannot be suppressed. And then you have poor execution of motor tasks due to hypotonia. Hypotonia, intermittent weakened hand grip, and milkmaid grip. So what is milkmaid grip, right? I always break up the words so it's not overwhelming to read it. What is milkmaid grip? Milkmaid grip is when you have decreased tone, intermittent, and weakened hand grip. That is. And tics, repetitive throat clearing, and emotional lability, obsessive compulsive behavior. So obsessive compulsive behaviors, well, we just talked about that. So you can actually get some behaviors that appear to be OCD, but on closer inspection, because this Sydenham chorea is part of the criteria for rheumatic heart disease, or the Jones criteria, then you should have in the back of your mind that these obsessive compulsive behaviors could be post-infectious. That's a cool little factoid and very hard question. So symptoms triad corresponded with what pathology? So symptoms triad represents what pathology? So I think it's AERD. So AERD is aspirin exacerbated respiratory distress, if I'm not wrong. Okay, respiratory disease. So it's aspirin exacerbated. So will you see aspirin in the question? Yes. In Samter's triad, the A is for aspirin. What is the A for in Samter's? Aspirin. What is AERD? It's respiratory distress. It's aspirin-induced respiratory distress. It's really the best way to think about it. And what is Samter's triad? So aspirin use, chronic rhinosinusitis, and asthma. So this is the one that I have trouble remembering. Fatigue, myopathy, decreased deep tendon reflexes. First thought for your intervention should be check TSH, because this is a myopathy highly associated symptomatically with hypothyroid. If you have fatigue, decreased DTRs, if you have bradycardia, if you have weight changes where you're increased in weight, think about thyroid, so you have to check the TSH. So why? Because hypothyroid can cause myopathy. Hyperthyroid can cause myopathy, I believe, as well. And so, but hypothyroid classically. And so what will your TSH be? It'll be raised. If it's normal, then you test ANA and anti-Jo-1 antibodies. Why? Because you have basically the myositis is associated with myositis, all kinds. Anti-Jo, anti-lock. So, and then ANA is a general autoimmune sensitive biomarker. Useful. So greater than 104 degrees Fahrenheit, greater than 40 degrees Fahrenheit, with no altered mental status. What is the diagnosis? So with no altered mental status, and if you're like stable, exhaustion. What would it be with altered mental status? You heat stroke, right? Actually less than. So heat exhaustion is characterized by hyperthermia that's typically less than 104. Less than 40 degrees. So excuse me on that. So it's less than 104, less than 40. 40 degrees is getting crazy. That is a crazy number. So if you have 104 degree temperature, you're not going to have normal mental status. So that's really the best way to think about that. Are you going to have normal mental status? At 104 degrees Fahrenheit? No. Diabetic ophthalmoplegia. There's 3 plus or minus clinical signs that you need. Diagnosis. What are they? There's cranial nerve 3 palsy, basically. You could say cranial 3 lesion. What is the right word? Somatic nerves. So what is that going to look like? It's going to result in like down and out gaze, actually. So you can even consider this one clinical sign. But then it spares the superficial parasympathetic fibers of the optic nerve. And so this is the clinical picture, but I think the pathophysiology is more important. So I want to do that first. So it's nerve ischemia from non-enzymatic consolidation of vasculature. You need 3 plus or minus clinical, positive or negative. clinical signs for diagnosis. What are the 3 signs? Criteria, actually. And so from 5 criteria. So they're not official criteria, guys, but this is just like 5 things that you should look for. You probably have 1 of these 5. You probably need like 3 of these criteria to pathology. So you have spares the parasympathetic fiber, so you're not going to have pupil constriction because the parasympathetic would be rest and digest, and pupil constriction is actually something you would do if there was enough light, right? There was like more than enough light. Whereas if you were being predated upon, or you're running from a predator or trying to chase a predator, you'd want to get as much light into your eyes as possible so you can see them moving with the rods of your eyes. Then ptosis is when you have a partial lid. It's not fully able to open. So, and then down and out gaze is where your eye is looking temporally and down. And then diplopia is where you have double vision from that down and out gaze. These are all related, very highly related, because they all have to do with ischemia, right? We're talking about a central infarction that is in the center, and so it's sparing the parasympathetics run along the exterior of the optic nerve, and so you would along the exterior of the oculomotor nerve, and so as a result of it being central, you won't have these pupil constriction symptoms. And then, so you have normal pupillary response and normal pupil size. Sorry for the opposite things of that one. Continuous murmur noted throughout thorax in multiple areas. Continuous murmur noted throughout thorax in multiple areas. And then increased blood pressure with heart sound. Diagnosis. Aortic coarctation. So this is just like a really simple one where the question was very detailed but very simple. So if you have a continuous murmur noted throughout the thorax in multiple areas, you have increased blood pressure and a fourth heart sound, you should be thinking about aortic coarctation because it's due to blood flow through a constricted aorta. And you should hear it at the infraclavicular area, anterior and left interscapular area, posteriorly. So the fact that it's continuous means that there might be collateral vessels that it's flowing through to try to bypass this coarcted area, which is a narrowing. So you probably have brachiofemoral delay and things like that. But this question was very hard for me because I'm trying to understand the diagnosis aspects of it, and I think it's very murmur-based, if I understand it correctly. I read through this explanation several times, and I did not have more clues than this, so it's good to memorize this kind of picture, but I should mention the locations of the murmurs. So it's infraclavicular area, anterior. And left interscapular area, posterior. So I can organize this, and I should because it's confusing, right? Where would the murmurs be? So I can take this. Oh, I've already just read it. and come down here this way. We'll put anterior here, real quick. Posterior, real quick. Three colons. This goes anterior. Posterior. Left interscapular area is posterior, infraclavicular area is anterior, and they're both continuous. So crampy abdo pain and weight loss and BRB, PR. So I like to break things up with hyphens. So that makes sense. So be right back. Bright red blood per rectum, right? So bright red blood per rectum. Okay. So what is the diagnosis? So usually with crampy abdo pain, 84-year-old male, pain, weight loss. So you want to be thinking about right-sided specifically. Right-sided. So, why not angiodysplasia? Because there would not be pain and angiodysplasia. However, there was abdo pain and cramps and this right-sided colon cancer. So if you fall and your patella rides low, there's pain back above the patella. Diagnosis. It's a quadriceps tendon tear. And this just makes sense visually. So like quadriceps tendon is above the patella. So what does the tendon do? It pulls. It can't push. Tendons don't push. Only bones push. So if a tendon breaks, what is it not doing? It's not pulling. What happens when you don't pull things? They get further away from you. So the patella moves away from the quadriceps. So what is the pathophysiology? You fall, you get a decel from falling, you get a sudden forceful contraction, and you get a ruptured quadriceps patellar tendon. And so then your patella rides low, right? So what if your patella rides high? It's likely to be a patellar tendon rupture. Patellar tendon is below the knee, so the knee joint. And so not below the knee joint, below the patella. Knee joint's a little more complicated. So that's the reasoning there. So you have a preemie, which is a premature child. I shouldn't say that term, but it's shorter. Pneumatosis intestinalis, and then necrotizing enterocolitis, right? So what are the symptoms? So NEC represents necrotizing enterocolitis. And what are the symptoms? There's four main symptoms, signs. So you have abdominal distension, gastrointestinal bleeding, hematochezia, hematemesis, and you have pneumatosis intestinalis, and feeding intolerance. So you have pain in your abdomen, gastrointestinal bleeding. So you have either you have it in your feces or in your throw up, which is hematochezia and hematemesis. Then you have pneumatosis intestinalis on imaging. And then you have feeding intolerance. So this picture in a premature child should tell you that you're dealing with necrotizing enterocolitis. And then what are the treatments? There's two. So you need to get blood cultures. What are the It's the workup. So you need antibiotics and you need blood cultures. You get the blood cultures first, obviously. When it doesn't work, what treatment? Laparotomy. So if the treatment doesn't work and they exacerbate or they appear scale signs or something like that, you need to do clinical deterioration like vital sign instability if you have acidosis. So mucosal fibroids, you get a hysteroscopic myomectomy, and then you get a 6-month unprotected sex. And then 6 months of unprotected sex, and it leads to 6 months without conception in a woman greater than 35 years old, and then 6 months without conception in a woman less than 35 years old. And then secondary amenorrhea, so they're not having menstrual cycle, signs of menstrual cycling. So what's the diagnosis? Asherman Syndrome. So what is that? It's basically symptomatic intrauterine synechia, which are syncytia. I don't know how to say it. Synechia. Look that up. But obviously I'm familiar with the word. It's just the pronunciation. But it's intrauterine surgeries. It can result in scarring, just like it can in any part of your body. Basically adhesions. And so it's fibrous material. It's going to get in the way of. So one of the keys to this is that what test do? You do a progesterone withdrawal test where you give progesterone and you take it away. What are the results in Asherman? They're negative. Why are they negative? They're negative even though the patient has normal estrogen and progesterone. And that's because of basically a lack of real estate. Because of the scar tissue, you can't lack tissue to proliferate in response to hormone changes. That makes sense. So basically, because of the scar tissue and the synechia, you're not going to have responses to progesterone and estrogen in your uterus. So what does procto mean? Procto means anus. What is FPIES? It's protein-induced enterocolitis. It's syndrome. So FPI is food protein induced. So both of these expressions have food protein induced. So I should say, what is FPI? Food protein induced. What is FPI? Yes. It's food protein induced enterocolitis syndrome. So what is seen clinically in FPI-AP? There's two of them. it's well appearing. So AP for well appearing and no pain, and then less than 6 months of age. Whereas if you were looking at food protein induced enterocolitis syndrome, you'd have ill appearing. And greater than 12 months, so older than 1. I just like to restate things in the dullest of terms. So, and then is food protein induced allergic proctocolitis. See that is FPIAP. Protein induced. FPIAP is food protein induced allergic proctocolitis IgE immune system. PIP is non-IgE allergic reaction. So there's those questions. Those questions come up all the time. What is USPSTF? I just wanted to get this program done because it's mentioned quite a bit. United States Preventative Services Task Force. That's United States Preventative Services Task Force. You want to break it into three words. U.S. Preventative Services Task Force. Don't ask me why they added task force. So, female of childbearing age, routine medical visit, always do well. Intimate partner, bio, I think this means violence training. Yeah. So you just want to check every single time if they're sexually active in childbearing age. Not even if they don't even have to be sexually active. MH versus thyroid storm. So what is MH? It's malignant hyperthermia. What electrolyte changes in both? So malignant hyperthermia, increased potassium, versus TS, which is thyroid storm. So that's a huge. You have hyperthermia, muscle rigidity, increased creatine kinase, and then you can have hyperthermia for both. You can have tachy for both. Muscle rigidity, usually not a thyroid storm thing necessarily. And increased CK, usually malignant hyperthermia, that's a huge sign. Really high, like should be 10,000 or above. Units per liter. Which of the airborne precautions, pathogens? So airborne is bacterial, TB. So airborne. So what is the smallest? Which precautions correspond to the smallest pathogens? Airborne, right? Because they have to be small enough to, I think they had a certain number of microns to be able to be taken up. So below, how small? Less than 10 microns. Excuse me, less than 10 microns. Less than 5 microns can be suspended in the air So you need to use airborne precautions. Greater than 5 microns. Be suspended for long periods. For a long time. Droplet precautions. The airborne precaution pathogens. So you have TB, and then for bacterial you have TB. So you have 1 for bacterial, and you have 3 for the viral. So you have varicella, you have SARS, varicella, SARS, and measles for viral, and then TB is your bacterial. So there's really only 4 to choose from. But for bacterial, there's only 1, TB. So all the others will be either droplet precautions or contact precautions. Just to read out your contact precautions. You have MRSA, VRE, you have Clostridium difficile, E. coli, you have scabies, and you have RSV. So there's really not that much to know, which is kind of intimidating for the subject. Substernal chest pain, cough, lasts for hours. Diagnosis is GERD. So if it lasts for hours, then you can call it GERD and not yourself do a workup on it. So what other characteristics make this likely to be GERD? So pain that lasting for hours is a huge one. Pain upon recumbency makes it worse, exacerbates. Pain and cough from like aspiration or cough reflex or vagal nerve. So if you have aspiration or cough reflex problems or vagal nerve problems, and you have pain plus cough, so it's like a painful cough. I'm sorry, if you have cough in conjunction with your substernal chest pain. Man, I'm out of it today. Anyway, sorry. So pain, nitroglycerin, no improvement. So pain, nitroglycerin, and it's not improving on nitroglycerin. So that's one of the key diagnostic criteria for workups for clinical suspicion actually for an MI. So what do you use to treat? You use a PPI. So labial adhesions, what are they? They're fused labia minora at the inferior, I should say posterior really, part of the decrease estrogen production. So if you're not producing as much estrogen as you should during ontology, which is development, then you might get labial adhesions, which is fused labia minora. And what is the treatment? You get topical estrogen cream to fix it. Aspergillus infection. You can get an aspergillus ball, right, in your lungs, so it's famous. So they like to test you on situations where it appears to be a ball, but it is not. So what are the distinctions between aspergillus infection and Hodgkin's lymphoma in the context of like a potential lung mass or cancer? So what history suggests aspergillus? So if you have a history of tuberculosis already, you can get a superinfection of aspergillus and get that ball right. Sarcoidosis is the same way because they're both granulomatous, right? bronchial cysts, neoplasms. So you just need to remember these bronchial cysts and neoplasms. But tuberculosis sarcoidosis, you should remember, you can get an Aspergillus superinfection. So bronchial cysts, neoplasms, or something also that can precipitate Aspergillus. But what kind of mass is Aspergillus? It's a cavitary mass, and it has air. It's air in the periphery. And so you have two sandwiching crescents, and so not a solid lung lesion. So what suggests Hodgkin's lymphoma? Origin of the mass. So previous history of Hodgkin's lymphoma, radiation chemo is key here. And then lung lesions, breast lesion, GI lesion. So what did we just mention? What are the three places it's likely to met? You can have lung lesions, breast lesions, and GI. And what other types of GI tumors are common? Gastric tumors and colorectal tumors. Hodgkin's lymphoma. So abrupt pain of malleolus unilaterally. Ankle pain. Ankle sprain. And then air stirrup brace. And then it's stabilized. So if you're stabilized by an air stirrup brace, you probably had an ankle sprain. Abrupt pain of malleolus unilaterally. So if you have unilateral malleolus pain, then you're likely to be an ankle sprain. Whereas gradual running pain, squeezing heel pain, stress fractures, radiological imaging in the foot. So if you have gradual pain, then you want to be thinking stress fracture. If you have abrupt pain, you want to be thinking a sprain, because you can treat it with an air stirrup brace as opposed to doing radiological imaging of the foot, which you would not need with an ankle sprain, given its abrupt nature. So if you had these symptoms, really, if you had malleolus unilaterally pain, it was abrupt, it's not likely to be a stress fracture, but that doesn't mean it can't be a fracture of another kind. So I'm not going to write down that this vaguely is always going to be ankle pain, ankle strain, because although you would have pain on the malleolus unilaterally, it could be other things you don't think that way. So MI leads to traumatic nightmare, traumatic event in life. Nightmares. So think of pathologies as things that can cause emotional trauma. Nightmares, and then diaphoretic wake from sleep, and then the diagnosis is PTSD, because it's been 2 months, and the diagnostic criteria for acute stress disorder is 1 month, right? So PTSD, so treatment is CBT. So gentamicin goes to like a positive whisper test, and then your hearing is diminished, and it's a positive head thrust test. So what's the diagnosis? So drug toxicity of aminoglycosides. ergo gentamicin. What does it affect? Vestibular system leads to head thrust, positive head thrust, and ototoxicity leads to decreased hearing. So gentamicin can, basically the moral of this story is that gentamicin can affect your vestibular system and lead to a positive head thrust test. And that is a test of your oculomotor vestibulocular reflex, which I think is your oculomotor. That's right, yes. And so that was the learning objective of that question. Ensure definitive diagnosis before breaking bad news. G6PD leads to Heinz bodies and bite cells, whereas sickle cell leads to autoinfarcts, functional asplenia by age 5, and then Howell-Jolly bodies. So don't get confused between. So I'm going to invert this question and say Howell-Jolly bodies lead to what? Diagnosis. Asplenia. Right? Not necessarily sickle cell, but asplenia. Right? And then Heinz bodies So Heinz body is basically DNA that's still in the cell, right? And so it's denatured hemoglobin, which should have been removed. And when they're removed, they become bite cells. And so it's associated with G6PD. Prior cervical surgery leads to increased risk preterm delivery. That's your next step. If you want to find out how thin the vaginal, the cervical length is. So the cervical length is taken you just think of the wall of the cervix, basically. So how thick is the wall of the cervix that's keeping the baby from falling out of the uterus, basically. So you want to do a transvaginal cervical length measurement. And what is that? Transvaginal cervical length measurement. So TVCL, what is that? It's transvaginal cervical length measurement. What length one is considered short. So if it's less than 2.5 centimeters, it's considered short. And less than 24 weeks. So if you're less than 24 weeks and your cervical length is less than 2.5 centimeters, then you might be at risk for a preterm delivery. And these are some fun facts. So neural tube is done forming at 5 to 6 weeks, so you should be thinking about supplementing folate after that time, because it won't necessarily help. It's fine to do it, but it's not going to change your chances of having just disturbances to the development process of the fetus. And then 24-hour urine, that in less than 20 weeks. If high risk for pre-eclampsia, probably do it anyway. What are urinary voiding symptoms? Dysuria, frequency, nocturia, and urgency. So dysuria, frequency, nocturia, and urgency. So there's the quote-unquote voiding symptoms of urination, basically. Dysuria, frequency, nocturia, and urgency. And what causes them? Decreased bladder capacity. So detrusor muscle becomes hyperactive because the capacity is decreased. Or you have bladder neck obstruction, or you have urethral obstruction. So you can have voiding symptoms from detrusor muscle hyperactivity, bladder neck obstruction, or urethral obstruction. So there's two types of obstruction, bladder and urethral. And then you just have this detrusor muscle hyperactivity problem from decreased bladder capacity. So in older patients with voiding symptoms, what do you think about first? You actually think about bladder cancer. Bladder cancer results in decreased bladder capacity, right? And so then you get detrusor muscle hyperactivity. And what are the three clinical findings? You get greater than one of these, greater than or equal to one of these. So what are the three clinical findings? You get painless hematuria, hydronephrosis, and voiding symptoms. Painless hematuria, hydronephrosis, and voiding symptoms. So if you have one or greater than these, so painless hematuria, hydronephrosis, and voiding symptoms, then you can potentially diagnose. What test do you do initially, first line? So first line equals urinary cystoscopy, not a Foley catheter placement. Why? Because unilateral decompression is done with a ureteral stent and not a Foley catheter. So if this is unilateral, then you want to use a ureteral stent. When do you use a Foley catheter? Prostatic hyperplasia, which is bilateral decompression. So these hydronephrosis and stuff like that, for bladder cancer, you're not going to use Foley catheter. You're going to do urinary cystoscopy because you want to see the bladder, basically. Acute mastoiditis. Okay. What is cholestatic pattern liver enzyme study? So increased alkaline phosphatase would be your clue there for cholestatic pattern. And then bloody stools plus abdo pain plus diarrhea for several years. What's the diagnosis? It's going to be PSC or PBC. So the answer is PSC. What is PSC? It's primary sclerosing cholangitis. And what is it associated with? Ulcerative colitis. So how do you diagnose this? You'd use MRCP, which is magnetic resonance cholangiopancreatography, I believe. Geopancreatography. So MRCP, right? Magnetic resonance cholangiopancreatography. So that's how you would diagnose PSC, which is highly associated with ulcerative colitis. This one here. What are the 5 stages of hyperkalemia on EKG or ECG? So it's PLWSA, so you have PR prolongation in addition, and ST depression. So this would be peaked T waves, I think. Yeah. And then this would be loss of P waves with ST depression. And then is widened QRS. And you have sine waves, and you have asystole. So I'm going to make an extra test down here. So what treatment? You give calcium gluconate. Okay, so it turns out that it's PR prolongation in addition to peak T waves and then ST depression. And loss of P waves. Then you have widened QRS. Then you have sine waves. Then you have asystole. All right, thank you so much. We'll be back.